Okay, hello. You've been diagnosed with a thoracic aortic aneurysm. The thoracic aorta is the largest artery that comes off the heart. It is usually about 3 centimeters in diameter. With aging, atherosclerosis, and hardening of the arteries, the aorta may start growing in size. We worry about it when it grows to 2 times the normal size. So if the normal aorta is about 3 centimeters, once it gets to be 5.5 to 6 centimeters, we worry about it potentially rupturing. When the wall of an aorta gets weak, it's much like a balloon as you blow it up. When you blow it up, the wall becomes thinner. The risk of it popping or rupturing is greater. And once it ruptures, obviously that's a catastrophic event. So what we are preparing you for is an operation to help prevent you from rupturing your aneurysm. There are 2 major ways of repairing this. The first is with endovascular therapy. This would be our preferred technique if we have an area above and below the aneurysm of normal aorta where we can land the endograft. The second would be open surgery. This is a big operation. It requires us to go into your chest and into your abdomen to repair the thoracic and abdominal aorta. What this does is allows us to put a clamp above the aneurysm, below the aneurysm, and repair the artery in order to prevent it from rupturing. Unfortunately, the thoracic aorta going into the abdomen has all the major blood vessels going to your kidneys, going to your small and large bowel, and also, most importantly, going to your spinal cord. Thus, the complications and risks of the operation are significantly greater than those of infrarenal or below the kidney aneurysms. Luckily, 95% of aneurysms are below the kidneys, but 5% of them are in the chest and extend into the abdomen, thus requiring an extensive repair. Once we identify a thoracic or abdominal aortic aneurysm, if it's not large enough that we worry about it rupturing, it is very important that we follow it closely. Unfortunately, aneurysms do not grow in a linear fashion. That is, we cannot predict the size they will be in a year or 2 years or 5 years. They grow in what we call a burst fashion, meaning that they will grow quickly over a short period of time. Thus, we schedule intervals where we will perform CAT scans or ultrasounds in order to evaluate it to see if it grows quickly. If it grows quickly, 4 to 5 millimeters per year, then that is also a concern for us, and we would recommend that you get treatment for this. But many, if not most, aneurysms will stay the same size once we identify them, and those patients may not require any surgical or endovascular treatment. There is medical treatment for the smaller aneurysms, which includes risk factor modification, quitting smoking, keeping your blood pressure under good control, keeping your cholesterol under good control. And these are important factors for not only slowing the growth of your aneurysm, but most importantly, creating good, heart healthy behaviors so that if we do have to repair your aneurysm in your chest or in your abdomen, it can be done when you are the healthiest that you can possibly be. Once we've identified a thoracic aneurysm, it is important for us to work closely with your family practitioner and cardiologist. They will ensure that you're as healthy as you can be to undergo any procedure. This is important whether we're just following the aneurysm with CAT scans or ultrasounds, or if we're deciding on doing an intervention such as endovascular stent graft therapy or open surgery. It is important that you can control your blood pressure, control your cholesterol, and you stop smoking in order to make yourself as healthy as possible. Once we've identified the aneurysm and we've decided that it's appropriate for you to undergo therapy, we need to get a special CAT scan in order to identify the exact anatomy. What this will tell us is where the aneurysm starts and where it ends. And it also tells us what blood vessels, i.e. the blood vessels to the kidneys, the small bowel or large bowel, are involved with the aneurysms and which ones we need to replace. This is exceedingly important in this procedure, as the risks of this operation, endovascular and open, are significantly more than for infrarenal aneurysms. After we've identified the anatomy using the CAT scan, many patients, if not most patients, will have to undergo an angiogram. This is even more specialized dye test that allows us to look at the size and takeoff or origins of the blood vessels going to your kidneys, to your small bowel, and to your large bowel. This helps us with the repair and helps us make this procedure as safe as humanly possible. The risks involved in thoracic aneurysm repair are significant. First, we worry about cardiac complications. That is why we involve your cardiologist from the inception of diagnosis to the completion of your care. Secondly, we worry about your lungs. Many of our patients are smokers, and so they need to make sure that their lungs are optimized so that they can get off the ventilator as quickly as possible and resume their normal activity. Also, there are some specific complications for thoracic aneurysm repair. The spinal cord arteries are involved, and the risk of paraplegia is not low, especially for open repairs, but is much lower for endovascular repairs. The risk of kidney failure is also a concern. If patients have kidney problems before the operation, they are at higher risk than patients who have normal kidney function. Also, bowel complications. Since we are re-anastomosing or connecting the bowel arteries that are involved in the aneurysm, this may involve some complications with the bowels during the operative period. In the first 24 hours after a procedure, what we worry about most is bleeding. We watch the patients very closely, either in our own vascular surgery intensive care unit or on our closely monitored floor. We look for low blood pressure, we look for a drop in your blood count, or we look at any other complications in your postoperative period. In the next 24 to 48 hours, we worry about pulmonary complications, about infectious complications, and bowel complications. We also watch very closely the urine output, because this will help signify whether your kidneys are getting enough blood after we've reconstructed this area of your thoracic aneurysm. Open thoracic aortic aneurysm repair is a complicated procedure. It involves teamwork. It involves a team of specially trained anesthesiologists, specially trained nurses, and specially trained vascular surgeons. This surgery involves opening up the chest and the abdomen and cutting through the diaphragm in order to get access to the thoracic and abdominal aorta and its blood vessels. We clamp the artery above the aneurysm and below the aneurysm, as well as the feeding blood vessels to the kidneys and bowel. This allows us to replace the entire segment with a plastic tube. We do this in a sequential fashion so that we can sew the blood vessels to the bowel and the kidney with minimizing damage to these organs during this long operation. When we bring you into the operating room, we first put a special tube that allows us to deflate one of the lungs, placed by one of the anesthesiologists. We also may place a catheter into the spinal column in order to drain fluid to minimize the risk of spinal complications such as paraplegia. Once this is performed, we can perform the surgery. The surgery itself takes between 4 to 6 hours and involves, as I mentioned, opening the chest and abdomen and isolating all the blood vessels. We first sew the artery above the aneurysm, then we will reimplant the blood vessels to the bowel and to the spinal cord, and lastly reimplant the kidney arteries. This will allow your entire bowel and kidneys and spinal cord to get the blood that you had before. Hopefully this will minimize the risk of paraplegia, but unfortunately this is a significant complication of the operation. Patients are usually in the ICU for 2 to 5 days on a breathing tube. This is partially because of the large volume of fluid that one gets during the operation, also because we have to cut the diaphragm in half, and this impedes one's work of breathing. Once the patients are strong enough, they're not requiring any more fluid, we can remove the breathing tube and the patient can breathe on their own. Once they're breathing on their own, they have a good urine output and their blood pressure is stable, they can go to the floor. Once they are eating, ambulating, and are reasonably comfortable, they can go home. This whole process takes between 10 to 14 days. We will see you in the office 2 weeks after the procedure, and then we'll see you 3 months later. For every operation, it takes about 6 weeks for you to resume about 90% of your pre-hospital energy as well as strength.
I'd like to not ever have a
thoracic aorta.
Yeah, that's horrible.
Sorry, I'm trying to make it as easy.
Worst one yet.
Yeah,
Wow.
It is the biggest operation on demand. That's what I just finished doing now, but
6 hours.
4 to 6. You might have to cut that part out.
Yeah,
Yeah, because after they hear it, who's going to want to have the operation? So we'll say,
they're lining up in general.